Welcome to Module 4 of the ABC Compliance video series. In this module, we will drill down on one of the key components of the anesthesia charge calculation and one of the distinguishing features of anesthesia payment, anesthesia time. Please note that the designation of anesthesia start and end time can only be established by the provider of record on the anesthesia record. There's no way to independently validate anesthesia times. Providers should not be concerned if times recorded by the OR staff differ. Anesthesia is the only medical specialty where payment is based on base units and the time spent with the patient. From the provider's perspective, this is an important and necessary feature of the payment calculation because the time is determined in large part by the speed of the surgeon. From a compliance perspective, however, this can be a little confusing and potentially risky. One never wants to be an outlier with regard to the average time for a given procedure. To sort out these issues, we will explore time from 5 dimensions: definition of anesthesia time, industry norms and exceptions, the potential impact of double dipping, the impact of handoffs and turnover in care, and medical direction issues, physician versus CRNA times. The standard definition of anesthesia time has evolved slightly over the years. Essentially, billable anesthesia time is the continuum of care during which there's a relationship of dependence between patient and provider. This classic definition applied well to the typical surgical case, but was not so useful in the management of labor by epidural. The ASA definition recognized the need to add up increments of time which would occur in obstetric anesthesia. There was also the reality of discontinuous time that might be associated, for example, with regional anesthetics. The point is that all time must be clearly documented. There's no question about the legitimacy of time documented by means of vital signs on the anesthesia record. But pre- and post-operative time could be questioned if not adequately documented. It's critical, for example, that transport time to the PACU or the ICU is adequately documented. It's important to remember that if a claim is questioned or audited, the auditor will only see what's on the record. The mantra of the auditor is not documented, not done. The reality of the specialty is that anesthesia times may vary significantly. While the average hernia might take an hour, there are a variety of specific conditions that might cause the case to take longer. Maybe the patient is morbidly obese. Maybe the hernia is just one of many procedures being performed during a given episode of care. Or maybe the patient experiences post-operative complications such as respiratory distress or malignant hyperthermia. Whatever the circumstances, the anesthesia record must substantiate every minute of time to be billed. There is a well-established convention that in-room time is an appropriate and reasonable start time, and it's an acceptable default. This having been said, there are 2 kinds of exceptions that must be kept in mind. If the care began in the holding area, it may be appropriate to include this pre-operating room time if 2 conditions are met. First, there must be continuous care during the time that is billed by the anesthesiologist or the CRNA. And second, there must be medical necessity for the inclusion of this time. This condition would be met, for example, transporting an unstable patient from the ICU to the OR. The other kind of exception has to do with situations where it's not appropriate to include all the time in the OR. Suppose, for example, that the patient's having an orthopedic procedure that requires a nerve block which is administered in the operating room prior to induction. In such cases, the anesthesia time does not begin until after the block is administered and the patient is rendered unconscious. You should not panic over the isolated case that has an excessive anesthesia time. Auditors typically look for patterns of abuse. The key to compliance is to make sure the time is well substantiated. What the government and payers are most concerned about are patterns of abuse where times are consistently longer than the norm. Medicare policy is particularly tricky on this point because Medicare payments are based on actual minutes of anesthesia time and not whole 15-minute time units. An analysis of your anesthesia times for Medicare cases should not indicate that more than 25% of your times are divisible by 5 or 10. Since the implementation of HIPAA in 1996, many other payers have adopted Medicare policy. A concept that should be well understood by all anesthesia providers is the concept of double dipping. Technically, this means you are getting paid twice for the same service. How could this occur? Consider the use of invasive monitoring and nerve blocks. They are all paid based on a fee schedule. So anesthesia time is being charged while a block is being placed. Then the provider is getting paid twice for the same time. This is why time spent administering nerve blocks for postoperative pain management or placing lines should not be included in the anesthesia time unless anesthesia had already been induced. If yours is a practice where the blocks are typically performed in the holding area before induction, you're likely going to be in compliance with the allowable criteria. But if you perform blocks in the OR, you want to make sure the coders know what time should be disallowed for the actual administration of the block. This applies to all unbundled services. Now let's talk about concurrency. Because anesthesia providers work as a team, we often see handoffs and turnovers. From a billing perspective, case time reflects the total time spent with the patient, irrespective of which team members participated. The ABC software, First Anesthesia, has the ability to track unlimited numbers of physician and CRNA turnovers, a factor which is critical to the determination of concurrency. That said, the system is only as complete and accurate as the information provided. Make sure that the record clearly indicates who is responsible for the case at all points. This leads us to a discussion of medical direction and concurrency, which are related but two very separate and distinct phenomena. Concurrency refers to the number of cases a provider is responsible for at any given moment. Even a physician working alone may have concurrent cases if this is what the documentation shows. Obviously, these are problems because one physician cannot be responsible for multiple cases simultaneously. Medical direction, by contrast, is a phenomenon first defined by Medicare, whereby a physician is specifically paid to oversee and manage multiple cases with non-physician anesthesia providers or anesthesia residents. For the record, this is unique to the specialty of anesthesia. Medicare guidelines and other payers are very specific as to the necessary conditions that have to be met and how the details of the configuration of the anesthesia team can be reported. We will discuss these conditions in more detail in a subsequent module. Our primary concern at this juncture is its impact on the anesthesia time reported. In most cases, the total times for the physician claim will match those of the CRNA, but this is not always the case. Just make sure that each provider's exact time is clearly noted. If you have questions about these distinctions and how they may apply to your practice, feel free to contact your account manager or the ABC coding department. Thank you for participating in this ABC compliance program. We hope the information presented here is useful to you in understanding the requirements of compliant billing. We greatly value your comments and feedback on this program. For more information, feel free to write to jody.lock@anesthesiallc.com or even to call 619-249-9801. Please pass along any comments or questions you may have to the ABC Compliance Department at compliancehelp@anesthesiallc.com.